Hello, my name is Pablo Minguez. I work at the Biocruces Vizcaya Health Research Institute and also at the Gurutzeta Cruces University Hospital in Baracaldo, Basque Country, in northern Spain. I'm going to talk about SPECT acquisition, reconstruction, and correction methods focused on activity quantification for dosimetry in molecular radiotherapy. So I am currently a consultant for Inmedica Pharma AB. So we know that if we want to determine the absorbed dose in molecular radiotherapy for organs and lesions, we have to know the activity distribution through time of the radiopharmaceutical or of the radionuclide in the organ or in the lesion. For that, what we currently use are or is a series of SPECT images. Those SPECT images are obtained with the photon emissions of the radionuclide. So to obtain those images, what we do is to acquire several projections of the patient, and then we obtain the SPECT image by reconstructing those projections. So there's mainly two reconstruction methods. First, the analytical methods, and second, the statistical reconstruction methods, which are iterative methods. For instance, there is the maximum likelihood expectation maximization method. Those iterative methods are currently those methods used because are less noisy than the analytical methods. So I will briefly summarize the iterative methods. In these methods, a cost function is defined, which is the log likelihood function, which represents the probability and the Poisson probability emission model of observing the measured counts for a given source. So we perform the iterations until we reach a predefined number of iterations. Here we can see a mathematical description of this ML-EM method, which this formula is the mathematical description where F is the estimated source value in one voxel for one iteration. Then we have the system matrix, which represents the probability that a photon in a pixel originates in a given voxel. And then we have the value, which represents the count in the pixel of one of the projections. Those are the measured counts. Okay, so regarding iterative methods, one particular case of the ML-EM methods are the ordered subsets expectation maximization methods, in which instead of considering all the projections, we consider only some subsets of the projections. So we have to decide the number of subsets and also the number of iterations. In this case, these numbers must be optimized because as we increase those numbers, we obtain a better recovery of the activity, but also we increase the noise. And I will give later a tip to optimize these numbers. So here we can see an example of how an increase in the number of iterations and the number of subsets increases the noise in the image. There are some algorithms which can improve precision, but it's at the expense of accuracy. So ideally, we would like that all photons reaching the detector go directly to the detector from the source, but there are some interactions in which some photons are absorbed, and other photons scattered, for instance. So those are the main image degrading effects in the acquired projections: attenuation, scatter, a geometric response of the detector and collimator, septal penetration, dead time, because the gamma camera behaves as a parallelizable camera equipment, and the motion. So for the attenuation, we will correct this. We will correct the image with the CT images. That's why we acquire also a CT acquisition. We perform a CT acquisition together with the SPECT acquisition. So the transmission method by the CT is used, and we obtain the Hounsfield units of each pixel. And photon attenuation can be modeled using a 3D map of the attenuation coefficients of the tissues in the patients. We obtained an attenuation map. For the scatter, the most used method is the triple energy window method, although there are also other methods, such as those model-based methods, which are appearing in some programs. But mostly we have the triple energy window method. In this case, we acquire also in adjacent energy windows to the photopeak window, and we use this formula to correct for scatter. With regard to the geometric response detector plus collimator, we can model the geometrical resolution as a Gaussian function with a distance-dependent full width half maximum. We can also correct for some motion that can appear if patient moves, also for breathing. For instance, if we can see in the sinogram if there has been some kind of movement, and we can correct for it. For instance, for breathing, we would use gating if needed, although, well, I think that there are also new techniques that allow us to correct for breathing without using gating. And lastly, we have to decide if we use filters, normally post-reconstruction filters. Those filters aim to reduce noise and its artifacts, but they degrade image resolution and increase parcel volume effect. So they are desirable for estimating activity distributions to calculate 3D dose metrics, such as dose volume histograms, but they are not desirable for quantifying total target activity. So if we are going to reconstruct the projections, we have to decide the attenuation correction, in which currently the CT images are mostly used. For the scatter, the triple energy window method, we normally will implement the geometric response, the correction for the geometric response of the collimator and the detector. We have to optimize the number of iterations and subsets. I will talk about this a bit later. And we will have to decide if we use post-reconstruction filters. So once we have the image reconstructed, we can go to quantify and obtain the activity. So in our image, what we are going to obtain in its voxel or its pixel is the count rate. Okay, so from the count rate, we will obtain the activity by means of a calibration factor or a calibration coefficient. it's good to remember that in our image will not be perfectly reconstructed because there will be noise, statistical noise or a kind of noise, and the spatial resolution is not going to be that good. In the CT images, the spatial resolution is about is lower than 1 millimeters, but in the SPECT image, the spatial resolution is higher than, it's greater than 1 centimeter normal. So it's recommended to use this kind of phantoms because these phantoms mimic reasonably well the attenuation and scatter properties in patient imaging. As I've said, the reconstruction is far from being perfect, and it's good that we use a phantom that can be somehow similar to a patient. So once we have acquired the image of the phantom, we will be able to convert the count rate into activity. So, but for the acquisition, we have to decide the number of projections, the time per projection, the acquisition matrix size. If we normally will use the body contour mode, and also normally the step and shoot mode. Those parameters should be those used in the clinical practice. We could change the time per projection because at low count rates, we will have a linearity in the counts measured. So once we have the image, we can obtain the calibration factor this way. We will draw an inner volume of interest, which is this green volume of interest. In this case, the activity is distributed, uniformly distributed in the cylinder, but we will define an inner volume of interest to avoid or to decrease the partial volume effect, because in this case there will be a compensation between the spill in and spill out counts. So the calibration factor will be the count rate in that volume divided by the activity concentration in the phantom. So that will be the calibration factor. But we are not going to determine the activity. If we determine the activity in one volume or in one lesion or in one organ as the count rate in that organ divided by the calibration factor, then we will underestimate the activity because of the partial volume effect, as we can see in this figure. Because in the image there will be many counts outside the volume of interest, the real volume of the sphere in this case. So to correct for this partial volume effect, what we do is to obtain with another phantom that we will see now, recovery coefficients, which can be defined as the activity concentration measured in the volume divided by the real activity concentration in the volume. We can use just activities instead of activity concentrations. So this way we are going to obtain a curve of the recovery coefficients as a function of the volume. So if we get this curve, we can extrapolate or interpolate the curve to obtain recovery coefficients for our volume. In this case, for the acquisition, we should use the same acquisition parameters as before. And with these spheres, we can optimize or we can try to optimize the number of updates. Here we can see a graph figure with different spheres of different volumes and different numbers of iterations. We can see that the number of iterations increase or the number increases, then the activity is better recovered. But there's a point in which improvement is not that relevant, but we only increase the noise in the image. So we cannot optimize the number of iterations as a compromise between the activity recovery and the noise in the image. Here on the right-hand side, we can see how if we include the correction for the collimator and the detector, we also get a better recovery coefficient, a better recovery of the activity. So now we can calculate the activity as the count rate in the organ or in the lesion divided by the calibration factor and the recovery coefficient for that volume. We may have to correct for that time, but this correction is not that common because it's only needed for well, of course, for high count rates. And in the case of luteation 177, when we administer 7.4 gigabecquerels, it's only needed within the first few hours after the administration of the treatment. And for iodine 131, for instance, when we perform treatments of high activities, such as neuroblastoma or neuroendocrine tumors treatments. But if we have to correct for it, we know that the observed count rate can be expressed as a function of the true count rate and the dead time with this formula. And then we can perform iterations to correct for that time. Ideally, this correction should be applied for its projection because it depends on the energy spectrum. But this cannot always be applied. And an alternative simplification of this correction is to perform an average correction to the reconstructed image, normally to the post-reconstructed before and not before the reconstruction. And it's based on the mean count rate incident over all projections. So I also would like to mention uncertainties. If we are going to calculate an activity, ideally we should also calculate the uncertainty in that number. And for that, I would recommend this EANM guidance document to calculate uncertainties in molecular radiotherapy, in dosimetry in molecular radiotherapy. And finally, I will talk about a little bit about segmentation. We have seen how to determine, we have seen the formula to determine the activity. But as I've said before, the resolution is quite poor in SPECT imaging. So the segmentation of the volume for which we want to calculate activity is not something straightforward. And it's important to know how to segment that volume. And for that, we will see several methods in the next talk. So thank you very much for your attention and see you in the next talk.